An infant spent a few hours in a San Francisco emergency room. Some formula, a nap under observation. No surgery, no overnight stay. The bill was $18,836, and $15,666 of it was a single line, trauma team activation. That's not a typo, and it's not fraud. It's the system working exactly as designed. So let's do something almost nobody does with a medical bill. Read it like an operator. The average American ER visit runs a few $1,000s, and the number on your statement can swing wildly for what looks like the same care. So 3 questions. What are you actually paying for? Why does one visit have 3 different prices? And who really pays? Because it's almost never just the patient. Start with the anchor number. For someone with employer insurance, the most acute tier of ER visit, a level 5, averages $3,855. The mildest, a level 1, averages $592. The ER doesn't really price the visit. It prices the uncertainty. A sore throat that turns out to be a virus, about $1,500. A urinary infection, about $2,700. Abdominal pain that turns out to be appendicitis, $9,500. You're not just paying for what you had, you're paying for everything the ER had to be ready to rule out. Across all severities, the average visit lands near $2,453, of which about $646 comes straight out of your pocket. Now open the bill up. Most people assume they're paying the doctor. They're not mostly. The single biggest piece is the facility fee, roughly 80% of the total. The doctor's work, imaging, and labs split what's left. The facility fee is the price of the room being open. And that fee is where the money moved. Between 2004 and 2021, the average ER facility fee rose 531%, from about $113 to $713. The physician's fee over the same years rose 132%. 2 things drove it. Prices per level climbed, and the mix of levels drifted upward. In 2004, the most expensive tier was about 5% of ER claims. By 2021, 20%. Maybe patients got sicker, but every hospital runs the software that assigns those levels, and every level up is more revenue. Layer on the sticker price itself. One study found emergency departments charge, on average, 340% of the Medicare allowable rate. That's the charge master, the list price. Almost nobody actually pays it. Here's the line that explains American healthcare better than any lecture. Take one item, a trauma team activation. Medicare pays about $957 for it. The average private insurer pays $3,968, and the top decile charge for the same activation reaches $13,525. One service, 3 prices, a 14-fold spread for the identical event. And this isn't a trauma quirk. Across the board, commercial insurers pay about 254% of what Medicare pays for the same hospital services. So the $4,000 ER visit is really a question. $4,000 to whom? Medicare has one number. Your insurer negotiates another. The uninsured patient gets handed the list price. Same care, same building, same hour. The price depends entirely on who's standing at the counter. To answer that, you have to understand one 1986 law, EMTALA. It says any hospital ER must screen and stabilize anyone who walks in, whether or not they can pay. It's effectively a national guarantee of emergency care, and Congress attached exactly $0 of funding to it. Think about what that does to the operations. A business legally required to serve customers who may never pay, running standby capacity around the clock. Something has to absorb the gap, and the gap is real. In 2020, hospitals reported $42.7 billion in uncompensated care, treatment delivered and never paid for. So the bill you're holding isn't really the price of your visit. It's your share of keeping the door open for everyone. The uninsured patient before you, the Medicare patient whose payment fell short, the trauma bay staffed on the quiet nights. Economists call it a cost shift. They argue about its size. The direction isn't in dispute. And the ER isn't a side door, it's the door. Roughly half of all hospital inpatient admissions now come through it. It's where the whole hospital's revenue, risk and obligation converge. It's not a store. It's the pressure valve for the entire system. Now the fair version, because the hospitals have a case too. All of American emergency care is only about 2% of national health spending. Only around 5.5% of ER visits are truly non-urgent. And standby readiness genuinely costs money. The blood bank and the CT scanner don't bill for the hours they sit idle. There's been progress. Since 2022, the No Surprises Act bans the surprise out-of-network bill for emergency care. Before it, about 18% of ER visits generated one, but it left your deductible, ground ambulances, and the facility fee itself untouched. So the $4,000 visit isn't a scam. It's the visible edge of a system built to keep an unfunded promise, and to send the invoice to whoever still has a payer attached. If you want the operator's view of how healthcare actually runs, the systems behind the bills in plain English, the breakdowns are at shanewelter.com/free. Next question in this series: why is the hospital always full, even when half the beds look empty?